cataract, we move on to another subspecialty, that is glaucoma. And we have Dr. Prasanna, Venkatesh, Ramesh. I'm not going to introduce him too much apart from saying that he is also interested in artificial intelligence, 3D printing, and academic filmmaking. So Dr. Prasanna, what is the challenge that you are taking up today?
Today is all about surgery. So we are going to learn, can I have my slides? Yeah. Can I have my slides? So today is about challenges from learner's basket. So I thought we'll have something which is very basic so that we'll all, how did I learn and how are we all, it's coming here. Okay, my slides are there. Can I have it there? Yeah. So it's flapping your trabeculectomy surgical wings. I'll be just quick. I'll take 6 baskets, each 30 seconds. We'll have basket 1. Taking the flap in the area of perforator. Never do this. When you see a perforator like this, never take the flap in the perforator. What happens if you take the flaps in the perforator? You see, I made this mistake. There is a perforator here. When I took the flap, see that it just comes, it keeps on bleeding. It's very difficult for you to proceed further. In that case, just take your cautery and just have a small touch with the cautery, and that's it. It's over. But then again, there is another perforator. As I keep dissecting and keep going on, I'm forwarding the video for want of time. I'll finish it quickly as promised to Sneha. And as I keep going there, again here, there is another perforator. So again, I'll have to keep going and do the same. See, I mop it and there is a perforator. So lesson 1, basket 1, never take your flap in the perforator. So this is all about case 1, or else you'll have a tough time ahead. Basket 2, bleeding from the surgical PA. Sometimes when we do a trabeculectomy, there is always a chance that once you complete your ostium punch and when you do your PA, you see I've done a PA, and suddenly there it starts a pulsatile ooze from the pillars of the PA and bleeding. Never do this. You saw me doing initial days I used to put saline, then what my mentor told is just use your flap, put a mechanical tamponade on it, and automatically things will settle through. So this is the second thing that I wanted to show you. Now see, it will be very tempting for you to put a saline because you can see the pulsatile nature of the bleed, but just put the flap and it'll automatically give you an area of tamponade and things will slowly settle in. Even if there is ifema, don't panic, it'll all settle down. So take 3 or the basket 3, trabeculectomy flap taken during AC collapse. See, in the initial days we used to use a traction suture. This was done by my fellow actually. I gave him to put the traction suture. It was a full thickness one. You can see the chamber has actually collapsed. Especially when we are going with only trabeculectomy, we don't have the option to enter into the AC and put visco. So you can see the flap, I don't have any counter traction force to actually take the flap. So without any counter traction force, slow and steady maneuver movements, and the flap is actually being taken. So you can see that the AC is almost fully collapsed, but the flap can be taken. Just follow the basics. Don't need to panic. Just keep the basics oriented. Hold your apex and take the flap in a very slow and steady manner. You have all the time in the world. Our idea is to give the best possible outcome, not the time of surgery. Take all the time in the world and it can be done. There is no need to panic. So that was my 3rd basket that I wanted to show. And I'm ending that basket by showing, see how difficult even I found my paracentesis to do because I didn't want to puncture the anterior lens capsule. So we'll go to basket 4, improper AC entry. Again, this is very, very important. A good flap will be taken. Sometimes when we are entering into it, a slight defocus of the surgical microscope and upward tilting of your blade. I just showed this. A mild upward tilting can cause a slight buttonhole, but you will have to recognize it on the table so that you don't handle with any buttonholing. So I was able to do that in this case, and you just need to change your side. Take 5, aligning your flaps. I'll just finish in a 10 more seconds. So in this flap, what happened was you can see that when taking the flap, this area, the flap slightly, the curve changed at this point. So that what happens is when you do a flap of this and when you try to do a single suture, you can see that the geometry doesn't align. So in these kind of scenarios, when you have a slightly curved flap like this in your initial days, never try to suture it with a single flap. The geometry will not align. Use 3 sutures, one here, one for this curve and one for this. And the last one is, is the base moving. This was one of my recently operated cases. I found there is something troublesome when I was trying to do this case. It was a block patient under subtenons, but something was not right in this patient. I was just not feeling comfortable. Once I finished my trabeculectomy and my cataract surgery, I just saw this patient that there was a mild seesaw movement that I'm just showing. You can see the eye was just moving in a seesaw movement, up and down, and we get all kind of possibilities when we operate. So these are my 6 baskets. I just wanted it to be as basic as possible. I hope it will be a good learning for all. And our idea is to move from here to here where we'll have a good flap. Thank you. That's all about. And I would like to acknowledge my mentor, Dr. Satyan Parthasarathi, who has been taught everything to me in glaucoma. Thank you, sir.
Thank you so much for that excellent talk, Dr. Prasanna. So we will take some tips from none other than Dr. Rastogi, who is the General Secretary, HOS, and one of our favorite teachers. Sir, over to you.
Yes, sir.
So, which you will prefer in trap?
Sir, I would prefer a corneal suture. For myself, it works better for me in my hands, and that's what I.
Basic teaching is bridal suture. Why not we are using bridal suture? Earlier it was a bridal suture teaching. Why we are not using?
So for me, sometimes we tend to have some. We do some topical trabeculectomy as well, sir. In our center, there is a culture where sometimes we end up doing a topical trabeculectomy as well. So at those times, this works.
Everybody is not perfect in topical.
Yes, I do agree. But as per your comment, bridal suture also can be followed. Yes, sir. I do agree with you, sir.
And you have say not one suture, 3 suture.
Yes,
so why not releasable sutures?
Sir, that particular instance, sir, releasable suture, I do agree, sir. That is also very much true. For that instant, we give steps to our fellows, sir. So at that step, what happened was, he came like this and then he went slightly like this. For that patient, a single suture did not give the geometry of closure. The AC was just not forming. So we had to release the apex there. I never put an apex suture there. It was about 3 sutures, which was a non-apex suture. Some instances where we needed to slightly go up, sir.
And in case of you said perforators,
yes,
so how do you change the site?
Sir, in case of maybe 1 or 2 perforators, maybe we can, if we are able to manage, then well and truly yes. If it's not been able to, or if it's very novice surgeon, then better to avoid, sir, actually in the first place, rather than.
That's right.
Yes, sir.
Better to avoid. But if you are accidentally met with this perforator,
sir, I'll try to use one burst of cautery. If I'm not able to get that, then I'll definitely contemplate doing that also, because I don't want to do over cautery and then cause a flap bed which is going in for thermal destruction.
Yeah, and another thing, that bleeding, you're reposing the flap to stop the bleeding.
Yes, sir.
So, suppose the surgeon is anxious,
yes,
he is not experienced like this.
Yes,
He is
sir.
trying to washing. How much time it will take and what will happen?
Sir, it just keeps coming. I have just encountered it only once or twice. In my so far the surgeries that I have done.
Yeah, usually stops.
The only point is, I remember my mentor telling me during my training that never do this, but I also ended up doing that only in the first place. Since it's an edited video, the same unedited video, for 5 minutes I was doing that. Then it came to my mind that he told me, right, why are you doing the same mistake? Then on the table I had to reassess. The same patient had mild ifema. It was 2 mm. We waited for 3 to 4 days and it came down. Maybe there is a chance that the ifema may not even come down also. But as of now, I have not encountered that in my practice so far, sir.
Sure.
Maybe you can throw your
Thank
views
you.
on it.
Thank you.
Yeah.
Nice tips.
Thank you, sir. I just wanted it to be a amalgamation of 5 to 6 snippets rather than a single case.
Definitely.
So that for the benefit of the.
They give you overall.
Yes, sir. More regarding the flaps in trap. Thank you.
Not one case, but they give you.
Yes, sir. You always make the triangular flap? Yes, sir. It's more. Sir, I have no experience on rectangular flaps, sir. I started my training with triangular and I'm still going with triangular, sir. Currently, sir, I have no experience in other than a triangular flap, sir.